Now we're going to start chapter 36, Immunology. So the next couple chapters are a little bit more complicated than some of the other things that we've talked about. Immunology is more of a cascade event, kind of like when we talked about the endocrine system. So there's not just one organ that's involved in the immune response, and I don't want you to confuse the immune response with an allergic response. We're going to talk about an allergic response in a couple weeks, or a couple of other chapters, but the immune response is a little bit different. So when we talk about an immunodeficiency, you need to understand there's two kinds of immunodeficiency. When I say the word immunodeficiency, I'm basically talking about the body's ability to resist disease. That's your immune response, is your body's ability to resist disease. And the immune system does basically four things. It is responsible for the body's defense against mechanisms, organisms invading viruses and things. It has a role in maintaining homeostasis, having the body maintain its level of autonomy functioning, like a normal level of function, like we talked about when we did fluid electrolytes, so the body always wants to maintain this level of homeostasis. The immune system also has a lot to do with surveillance, and it's constantly monitoring to find out what organisms are being invaded, what viruses are being invaded, and it will recognize invading pathogens and initiate an immune response in the presence of invading pathogens. And then the people who have a compromised immune system, we call that an immunodeficiency. People that have immunodeficiencies are much more likely to develop infections. They can't fight against invading pathogens, but at the same time, their signs and symptoms of infection that we would normally see in a regular patient, high fevers, high white blood counts, things like that, those tend to be masked, so they don't have the same kind of inflammatory responses, like they're like redness, inflammation, things, those tend to go down because they have an immunodeficiency disease process going on. The phagocytes, the B and T lymphocytes, those are the main three components of the white blood cell system that are involved in the immunodeficient response. Now, if you remember back to when we talked about hematology, you'll remember that those blood cells, when they are dividing into their different categories, they will divide into platelets, red blood cells, or the white blood cells. And you'll recall the white blood cells get cascaded into quite a few different things, some of them being involved in the immune response, specifically the phagocytes, the T and the B lymphocytes. So I want to talk first, let me show you this here. So I want to show you all of these different organs that are involved in I'll stand over here because I think it just went out of the camera. All of these organs are involved in the immune response. So you can see it begins way up here in the beginning, like with your tonsils. All of the lymph nodes that we've been talking about through this whole semester. You've got lymph nodes in your neck and your axilla and the groin. All throughout the body you have lymph nodes that are very involved in the immune response because they carry these different phagocytes and T cells and B cells throughout the body via the lymphatic system. Your spleen is highly activated. You've got a lot of immune response in the gut. And you'll remember we talk a lot about normal flora, normal gut flora, meaning there are healthy good bacteria, and the healthy good bacteria will then fight bad bacteria in a person who has a normal functioning immune system. People who don't have a normal functioning immune system tend to get infections in that area, and people who have immunodeficiency is one reason they have chronic diarrhea because of this immune response in the GI tract. Again, you've got lymph nodes down here in the general region. Your bone marrow is also very involved in that because that produces, your bone marrow is a big proponent of blood cell. It's a blood cell producer, and as well as the lymph nodes of the groin. So let me go back to talking about the different kinds of immune problems, and you kind of need to know that there's a primary immunodeficiency and secondary immunodeficiencies. Primary immunodeficiencies are by far less common, and primary immunodeficiencies tend to be more of a pediatric disease process. You'll study more about this when you take pediatrics. So it is in your textbook. I do want you to skim through it, but really you don't need to focus on some of those more obscure disease processes for adult health. Other than I do want you to know that primary immunodeficiency is known as intrinsic, meaning you're born with it. It's innate, and it typically shows up in babies. And as the embryo is developing, there's an organ called the thymus. And the thymus doesn't last very long, but in the developing baby, it has a lot to do with immunology and a sound immune system. When that thymus is not developing properly, or the baby doesn't have it or is born without it, the baby often has failure to thrive. They will get an awful lot of infections. They can have some cardiac complications. They have poor nutrition because they are so prone to so many different kinds of infections, and because they're young, they don't have any of the natural built-in immunities that people develop as they age and as they've been more exposed to pathogens, and I'll show you a little bit more about that later. But I do want you to look at table 36.1 and figure 36.1 in your textbook, because that does describe some of the primary immunodeficiency problems that you will see. So again, just kind of give an overview of that, but like I said, you're going to look at that a little bit more when you when you take your pediatric rotation. The thing that I really want to focus on for adult health is secondary immunodeficiencies. Your secondary immunodeficiencies are really more external things, and these are things that are brought on by infections, like overwhelming infections, especially people who are getting like septic, like that overwhelming kind of infection we talked about last semester. Their body gets overwhelmed, it overwhelms the immune system, they start developing immunodeficiencies. It can lead to like your patients who have chemotherapy. Chemotherapy will, it wipes out fast-growing cells. Well, your white blood cells are rapidly producing. And so if a patient is getting chemotherapy, it is knocking down their white blood cells, and hence will lead to more and more infections and causing immunodeficiencies. But that's a secondary cause of it. But a lot of your patients who have overwhelming infections or are dealing with chronic stress, chemotherapy, things like that, will become immunodeficient, but it's not that they were born with it, it's that their body is getting overwhelmed or has something else going on. But you need to treat, as a nurse, you would treat both of them the same, because both of these kinds of patients with both a primary and secondary immunodeficiency are at very high risk for developing infections. So while you always would do your hand washing and things like that, you need to be especially vigilant in your patients who are immunosuppressed or immunodeficient. Those words are used interchangeably. You're going to want to use things like good hand washing. You would teach your patients to avoid large crowds, to avoid a lot of handshaking with people. If they're out in a crowd, you know, this would not be the time to shake hands, hold babies. Airplanes are terrible because everybody has to share that same air, so they might want to wear a mask or something if they have to be on an airplane. So those are the two things I want you to just sort of look at when you're looking at the different kinds of immunodeficiencies. Another thing that when we're talking about immunodeficiency, if your patient has a decreased white blood cell count, we call that neutropenia, low neutrophils. And when your patient, it does have neutropenia, again, they're going to be at higher risk for infections, higher risk for immunodeficiency signs and symptoms, which are going to be things like they are going to have more infections than you would expect, or they'll come into the hospital with an infection. You put them on antibiotics and they're not responding to those antibiotics very well. Failure to respond. They're going to have an increased diarrhea, like I just told you about over here, because of the decrease in the normal flora. They're also at higher risk for developing some of the autoimmune disorders. And an autoimmune disorder is where the body attacks itself. The body thinks that something that is supposed to be there is actually, the body's perceiving it as a foreign object, and so it starts attacking itself. And I've got a video I'm going to show you a little bit kind of what that looks like. Some of your autoimmune disorders are going to be like lupus. Your patients who have lupus, systemic lupus erythema, they can develop this butterfly rash across their nose and cheeks. That's a classic sign of lupus. They tend to get puffy, thin skin. They are very sensitive to sunlight. They should not be in the sunlight. They need to protect themselves because they have a lot of skin disorders. That's because the body is attacking itself. Rheumatoid arthritis is another autoimmune disorder where the body is actually attacking the synovial fluid in the joints. Very, very painful. There are some medications and stuff out now, but what you want to do in your patients who are developing these autoimmune disorders is you actually have to stop the immune process. And so you put them on steroids. You do the same thing like in your patients who have organ transplants. So a patient who has an organ transplant, you're putting a foreign object in the body, like a new organ, and the body will naturally think, oh, that's a foreign object, and they want to attack it. This immune system will attack the new organ. So your patients who are getting organ transplants, you have to put them on we call them anti-rejection drugs, but basically what it is it's anti-immune therapy. And so you are deliberately suppressing the immune system, so you're tricking the body into thinking that these the foreign organs that they've just transplanted aren't foreign. So those patients who have had any kind of transplant are also at high risk for infection because you are suppressing that immune response. Did I tell you? I want you to look at, in your textbook, I want you to look at chart 36.1. Sometimes in your patients who have overwhelming infections or they're immunodeficient, we will treat them with different things. A common thing that we treat them with is IV immunoglobulin therapy. And when you treat somebody with immunoglobulin therapy, that helps boost their immune system. You need to be a little bit careful when you're, you need to be a little careful when you're treating somebody with, well, see, now that is annoying. Sorry, hang on a second. When you're treating somebody with immunoglobulin or just like blood products, any product like that, you need to be careful that your patient is not going to develop an allergic reaction, and you watch them very closely because they are at a little bit of a higher risk. If they're getting IVIG, intravenous immunoglobulin therapy, you need to be careful that they're not developing a reaction. Some of the reactions that patients can have, the most scary one is anaphylaxis. They'll start itching, having trouble breathing, their throat will start swelling up. It is imperative, if you're giving blood or immunoglobulin therapy, antibiotics can do this too. If your patient starts developing an allergic reaction to that, we'll talk a little bit more about allergies in a couple chapters. Stop the infusion immediately. That's step one. Just stop the infusion and get, and if you can disconnect it at the hub so they're not getting all of the, like the blood or the antibiotic or the immunoglobulin, if you can get it out of the tubing and then just put saline in there. Epinephrine, because you want to give epinephrine to stop the inflammation. You're going to want to give Benadryl. If they're starting to have trouble breathing, you might want to give them a bronchodilator like an albuterol or something like that in order to reverse this allergic response to whatever you're trying to treat for the immunosuppressive problem. So keep that in mind. What else do I want to tell you about this? Here's another thing I wanted to tell you before I go into the antigen antibody thing. The other thing I want to tell you about the immune system is that as a person ages, their ability to demonstrate a normal immune response decreases. So in the very young and the very old, you need to be careful that because they're not going to have the same immune response. They're not going to, like if they cut themselves, they might not get as the normal inflammatory response. They might not get normal redness. They might not spike a fever if they're infected. They might not display the same kinds of signs and symptoms of an immunodeficiency like somebody that is not very young, very old. So you do need to assess that. Be careful also with patients who are smoking a lot, who drink a lot of alcohol, maybe their nutritional status is not adequate, maybe their stress level is very high. Patients that are in those scenarios also have very high cortisol levels or low nutrition, and their ability to also fight infection is diminished. So patients who have other reasons that they might not be able to fight infections and they're also developing an immunodeficiency, those things can add up and make the situation even worse. So you want to do a really good assessment on your patients. So the other thing I wanted to tell you guys about is the difference between the other thing I wanted to talk about, so with immunodeficiency, you've got the primary and secondary. You also have innate immunity and acquired immunity. And so your innate immunity, those are the things that are present at birth. And this is your first line defense against pathogens. So your innate immunity, that is like, it's a non-specific response. Everybody would have the same kind of response. It's not in direct correlation to a specific antigen. It is, everybody would have this. This is why it is so important for mothers to breastfeed their babies, because a lot of this immunity can start developing between the mother and the baby through the breast milk, because the mother's immunities then can get transferred into the baby. So that is called innate, and I don't have any other room up here to write on my board, but that's an innate, I-N-A-T-E, immunity versus an acquired immunity. An acquired immunity is something that is developed. You develop it over time. And the developed acquired immunity can either be active or passive. And this is why we give babies vaccinations, is because we will introduce a little bit of an antigen and then the body will develop an antibody towards that. And so active versus passive is, if like in an active one, you've actually had the disease, either like you've either been vaccinated against it, you've been given a little bit, or you've actually had the disease, rather than getting like a passive immunity. And I'm going to show you a little bit about what that looks like. Let me pull up this slide on the immune response. Okay, I'll move my thing. Hang on.
Activation of the immune response typically begins when a pathogen enters the body. Macrophages that encounter the pathogen ingest, process, and display the antigen fragments on their cell surfaces. Macrophages with antigen fragments displayed on their surfaces are called antigen-presenting cells. An antigen-presenting macrophage interacts with a T helper cell that can recognize the same antigen. During the interaction, the macrophage releases a chemical alarm signal called interleukin-1, which stimulates the T helper cell to secrete interleukin-2. Interleukin-2 causes the proliferation of certain cytotoxic T cells and B cells. The immune response from this point follows two paths, one using cytotoxic T cells and one using B cells. Normal cells of the body that become infected can also digest some of the pathogens and display antigen fragments on their cell surfaces. The body makes millions of different types of cytotoxic T cells. Each type is able to recognize a particular antigen. The cytotoxic T cells that are capable of recognizing the antigen displayed on the surfaces of infected cells bind to the infected cells and produce chemicals that kill the infected cell. Death of the infected cells results in destruction of the pathogen. B cells